If you are tuning into YouTube, we are just about to start recording, so bear with us for a minute. You are behind the scenes with our esteemed panel. Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and various other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Today's episode is being brought to you by our friends at BeneLynk. BeneLynk is one of the most innovative dual advocacy organizations in the country. Their mission is to improve people's lives and positively impact social determinants of health barriers by granting their healthcare partners with the information they need while providing healthcare consumers with the advocacy they deserve. They use innovative technology that enables their people to have dynamic conversations, which flows organically to meet social determinants of health challenges, and as such are able to build stronger human connections, which is so critical. And it is this carefully planned combination of technology and the human touch that generates true results, exceptional results. I talk to a lot of organizations in this space, and I believe that BeneLynk is truly changing the way the healthcare industry communicates and builds relationships with consumers with complex healthcare conditions, and believe they are a true bright spots in our industry. So I encourage you to check them out at BeneLynk.com. I'm going to spell that for you, www.BeneLynk, BeneLynk.com. And you could informally pick their brains anytime about all of the topics tied to social determinants and advocacy around both your partial and duals. And that's the topic today, is how to convert your partial dual members to full dual eligible members. And we have a great set of guests today. We have three of them, and I'm going to introduce them to you right now. Our first is Josh Weisbrod. He is the Vice President of Risk Adjustment at Network Health. He has over 20 years experience in the industry, health insurance, healthcare analytics, human services, working with local and national companies and state and federal agencies, specializing in health plan operations and data analytics. Very excited to have Josh here from the great state of Wisconsin. So welcome to the show, Josh. We also have Sean Libby. He is the president and co-founder of BeneLynk. He has worked at the intersection of managed care and government benefit programs for the past 19 years. Prior to BeneLynk, he served as the president of Freedom Disability and Alpha Disability, one of the nation's largest Social Security disability and veterans advocacy companies. And before that was the vice president of sales for SSC Disability, providing government programs, benefit services for managed care organizations. And last but certainly not least is Keslie Crichton. She is the Chief Revenue Officer at BeneLynk. She's got over 25 years of comprehensive managed care and healthcare technology experience. Prior to BeneLynk, she spent well over a decade at Change Healthcare and its predecessor companies, Altegra Health and Social Service Coordinators, helping plans improve risk-adjusted revenue and quality performance scores through dual enrollment and retention. So really happy to have the three of you here today. I think it's a great mix of expertise to cover the topics we're going to cover. So let's start off and set the stage. I'm going to bring in Josh Weisbrod. Josh, why don't you explain to everyone why it matters so much to you whether members are full or partial as far as eligibility goes?
Sure. No, thanks, Eric. So most folks in the industry understand that Medicare Advantage plans are paid based on the members' demographics and then based on their diagnosis codes. And that's really what the industry focused on originally and really continues to focus on. However, what a lot of people don't understand is there are a lot of other statuses that members have, like dual eligibility and Medicaid eligibility, that really drive revenue. So if you convert a member to partial dual status, you will receive a bump in your premium payment from CMS. If you convert them to full dual status, you'll receive an even larger bump. The benefit to us is obviously the revenue. The benefit to the member, especially if you have a D-SNP plan internally, is that you're really coordinating benefits with the state Medicaid agency and with Medicare. And those members receive discounts on their premiums. They receive subsidies. So it's better for both the payer and for the member.
Okay, so let's provide some background here. Why is, and I'm going to bring in Sean, Libby, and Josh, stick around. We're going to have you jump in on this too. So why is this such a relatively new challenge or issue for health plans? And give us an understanding of maybe how much revenue is being left on the table by health plans.
Sure, I can take a stab at this and I'll turn it over to Sean. So it's probably a relatively recent or new phenomenon because, again, when risk adjustment first started as a payment mechanism, people were focused on the diagnosis codes. It was new. Providers do not focus on diagnosis codes. They focus on CPTs because that's how they get paid. And so once that sort of learning curve fully matured, the payers started realizing, okay, if we convert these members and get them additional benefits through the state Medicaid programs, we also get more revenue. And that's probably occurred over the last 4 or 5 years or so, and ramping up to now. What's happening is that plans understand the larger percentage of dual eligible members that you have, the higher risk score and the higher premium you're driving for your Medicare Advantage program. And, in our example here in Wisconsin for Network Health, where I'm working today, is, we have a small D-SNP program, but we have a lot of Medicaid Advantage members, and many of them could be eligible for Medicaid. And if we convert them to dual status, it helps both them and both us. So, Sean, any thoughts?
Yeah, thanks so much, Josh. And thanks, Eric, for having us. Josh really laid out a lot of what I think is the important part to consider in this. It matters whether or not a member can become a full dual member. And that matters whether it's a member who's not yet dual or a member who is currently partial and they can become full. Just to throw some numbers out there relative to what Josh said. If you look at the increase in the Medicare Advantage capitation, so not even considering anything relative to the Medicaid side, if you get somebody to be partial, you see about a $25 PMPM lift. If you get that person to full, you see about a $250 PMPM lift. So they're both good, but the full dual is a lot more capitation. And that's just to reflect the fact that historically, just in terms of the Medicare side of the house, fully dual members tend to be more costly. They have historically had less access to care. So when they're coming into the Medicare world, they're paid, the plan is paid at a higher rate because of that. So it's real dollars associated with this for the plan. And it's really important to the member that they get all the benefits that they deserve. So this is something that's become increasingly important since 2017, when CMS changed the methodology to make it so that they differentiated between full and partial duals. So it's always mattered to the member, but now it matters even more to the plans because they can get that delta between getting a $25 lift and a $250 lift. And that's really why we're talking about this. That's why it matters in terms of the finances, and it matters so much in terms of the member benefits.
So that's if you're a Medicare member, and they're also going to be Medicaid eligible, we're looking at a 10 times increase per member as far as revenue goes. And I imagine that number is even greater if you start with as a Medicaid member who hasn't yet become eligible from MA. Is that correct?
Yeah, it's a significant, it's a really big increase, right? So it's a great increase if it's just partial, that $25 PMPM drops to the bottom line, but $250 is obviously just a lot more. So it's a meaningful financial impact.
And just to add to the cost of that, right? When CMS started evaluating to change this model in 2017, they looked at the cost of partials compared to full, and the full duals were spending upwards of 35% more annually than the partial dual. And that's what prompted this whole model change, right? Based on like 2012 data, when this first started, a partial dual had annual costs of about $10,000. The fulls had 35% more, $15,000 is what their costs were. And so those that were managing D-SNPs, we're getting a little short change when the capitation, the Medicaid add-on was the same for both populations.
And as a percentage of revenue, if you look at this, your bid rate might be $800 to $1,000 per member per month. And, if you're getting an extra $250 per person, that's a 25 to 30% increase over that monthly revenue before you even submit their diagnosis codes for payment, right? So that's a guaranteed monthly capitation payment for your plan.
So what are some of the additional, I'll call them nuances around the revenue opportunity for health plans and maybe the lift that people listening may not be aware of? Like, why is this so difficult, Josh?
It's difficult because Medicaid is so complex. So a lot of our members who are Medicare eligible and would likely qualify for Medicaid based on income or other criteria don't know that. So you need to reach out to them and explain and then help them enroll in these programs through the state Medicaid agency so that they are then identified by CMS as duly eligible. The process is different in every state. You really need experts in each state to help you and help your member walk through that application process. And it's really dependent on the member taking action sort of on your behalf to get enrolled in this program so that then you see that status come through on their Medicare eligibility files.
So and when we were talking prior to pressing record, you'd mentioned to me sort of the pillars of risk adjustment and how that also plays into some of the challenges that health plans have in maximizing the revenue here. Could you go over those for us?
Sure. So, the expectation is that all of your members go in for a visit, typically, an annual wellness visit or a PCP visit. We know that doesn't happen. It's getting better, but it's up to the plan to help the provider community and the members get in to be seen. Then, as I mentioned earlier, providers aren't really focused on diagnosis coding. They're focused on CPT coding because that's how they get paid. So they submit the CPT. The insurance company pays based on the CPT, typically not the diagnosis code. The diagnosis codes are important to us. We need to make sure that there's both documentation in the notes and then a code on the claim that is supported by the documentation. That is a challenge, and that's something the industry is still working through. And then as far as the other pillar is, once you collect all that information, whether it be on claims or through other means, so an in-home assessment, for example, or a medical record review, you have to submit all that data to CMS accurately and completely to make sure that you get paid appropriately. And there are a lot of edits in place for those in the industry that are familiar with the process that can keep your data from being accepted by CMS. And for every diagnosis code that is lost, you're potentially leaving revenue on the table, which then harms you going forward when you're trying to build new programs and offer new benefits and reduce your premiums for members. So those are really the challenges and kind of the focus of historical risk adjustment. And now we've hopefully evolved into looking at other statuses for our members like dual eligibility.
So I want the listeners to understand every single nook and cranny here, because we're eventually going to talk about tactics and strategies to make sure we are maximizing the revenue. And I want folks to be inspired to bring these ideas back to their organizations. So Keslie, as any additional nuances or things that our listeners need to be aware of as it relates to the challenges that they may not be aware of, or maybe they're not even addressing right now?
Yeah, as Josh alluded, Medicaid is really complicated and it literally is dealt with at a state level. Some states have one common application for a Medicare savings program, which gets somebody partial. Some states have, and full. Other states have different applications. Just to give you an example, New York, the Medicare savings program application is about 2 pages long. To apply for full Medicaid is like 28 pages. So you have resistance from both the vendor or the plan that might be doing this, the member that has more documentation and drilling down for their eligibility. And then you have all different pathways into full Medicaid that you really have to know about. So as Josh and I were talking about in Wisconsin, there's working disabled, right? It's called the MAP program, Medicaid purchase. So you have higher income and assets in some states if you're a working disabled person, still meet that criteria. But you, as the health plan or your vendor, has to be aware of all these different challenges that might be out there, and also the different eligibility criteria to help identify those members. So you don't just say they're over income or they're over assets, that you understand that there's other pathways.
So Josh, how does this fuel Network Health's overall strategy to just build a better connection with your consumers, with your members?
Sure. So we have about 72,000 MA lives currently, and about 2,500 of those are dual eligible. We know that there are more dual eligibles in our population. We just haven't identified those yet. So our strategy is to take the remaining 70,000 people and identify if they qualify as partial or full dual, and then get them enrolled with our assistance. Because again, Medicaid is so complicated. Wisconsin in particular has multiple programs for, as Keslie mentioned, working disabled and other folks who qualify for Medicaid. So to walk them through that process, get them enrolled, and then eventually, because currently CMS and each one of the state Medicaid programs are beginning to require more coordination between your DSNP programs and your state Medicaid agency and coordination of benefits for those members. So ideally, we will expand our DSNP population, expand our county reach, and enroll more dually eligible members to help them and use sort of our homegrown customer service and outreach to provide better Medicare and Medicaid coordination for those populations.
So you're using some homegrown capabilities, but I'm assuming to connect and really deal with some of the idiosyncrasies that relates both to Wisconsin and the challenges of reaching these complex members. You're going outside for help there.
Oh, absolutely. So we don't have the internal capacity, resources, and really the knowledge base right now to reach out to a member and walk them through the application process. And so, we're currently working with BeneLynk to do some of this work for us, to make the phone calls, to discuss with the member that these opportunities may be available to them. And then if they're willing to walk through the process, to actually sit down and go through the electronic eligibility application for Wisconsin Medicaid for these members. For us, it's been a great program. It's relatively early, but I think the members are going to find real value here. And I do think, from a plan perspective, being a small regional health plan in Wisconsin, we sell ourselves on better customer service, knowing our members, and getting them as additional assistance can be really impactful in their lives. These are reduced premiums for Medicare. These are other assistance programs within the state of Wisconsin that saves them money. So I think our entire goal is to build a more coordinated healthcare system that is working directly with the member to help them access healthcare. And BeneLynk's helping us do that.
It's great. And so what I want to do now, I want to talk about some examples, some bright spots. I'm bringing Keslie and Sean to do that. And then we're going to get into sort of roadmap and the things that everyone needs to have in place to accomplish, and replicate the bright spots that we're going to hear about. So let's do that. In between, I may talk about revenue pathways, guys, but I'm going to bring in Sean Libby here first, to share a bright spot, and then maybe Keslie, I'll have you warm it up in the bullpen. Maybe you'll share a bright spot as well. I want to get into examples so that we could truly understand how other organizations around the country are tackling this successfully. Go ahead, Sean.
Great. Yeah, I wanted to share kind of a particular case from one large national carrier that we're working with to do this type of work. Really there's two categories that we're talking about: identifying people that are not dual and helping them to become dual, ideally full duals, and then the partial duals and helping them to become full duals. So identify those partial duals who would meet the criteria to become full duals. And it's really that second one that I want to talk about a little bit. And I looked up the case of this one specific member using the name Pang. He's a 55-year-old man in New York. And when we looked at his case, he was classified as partial dual. He met the ABD standards for assets, but his income limits were just above ABD. So that's why he wound up as a partial dual, right? But when we looked at understanding the New York specifics,
Can we define ABD real quick, Sean?
Sure. ABD is the aged, blind, and disabled category, right? So it's a wide category within Medicaid that tends to be at the higher capitation rate. It's a pathway to full Medicaid, as distinct from things like the Medicare Savings Program, which are QMB, SLMB, and QI, right? So there's a lot of pathways to each of these, but ABD is one of the big ones that get you to full dual benefits. So we're looking at this one particular member, and they met some of the standards for full, but not all of them. And so they wound up being categorized as partially dual. So what we saw, though, is that there's a specific New York program, that the surplus income program for disabled individuals, which is what Pang was, where there's this opportunity to get them full dual benefits on the basis of their medical expenses. So we understood this is a disabled individual spending a lot of money on this. So we were able to get him full dual benefits, get the plan, the appropriate capitation. So it's really a good outcome for everybody. And for this carrier, we're looking at DSNP members throughout the country, right? And DSNP matters because it's where there are partial, we think of DSNP as a lot of time as full duals, but there's a lot of QMB members, QMB members enrolled in DSNP plans. Where there's that opportunity to look at those people and see if some of those partial duals can become full duals. And the work that we're doing on behalf of this particular client, we've been able to engage thousands of members who are partial and look at their opportunity to potentially get them full. We've already had hundreds of members get approved to become full dual, to get full dual benefits. So it's so meaningful to take that subset of the population. They're going to stay in the DSNP. All you're going to see is that increase in capitation, and the member sees the increase. And it was all kind of enabled by the fact that we were looking at New York specifically, understanding what are all the different options for Medicaid in New York, engaging with this member, understanding their particular circumstance, and finding a way to get them that higher level of benefits.
Let me ask you a couple of follow-ups to that. So first, let's go, and I know we're using a fake name, but you called this individual Pang. So
yeah,
what did it mean for Pang specifically from just an overall healthcare experience? Could you give us some enlightenment there? I want to get to the human part of this, and then I'm going to circle back to the business.
Yeah, what it means at this point is that Peng is fully dual, right? So he has access to all Medicaid benefits and all Medicare benefits, right?
Were there clinical services that he wasn't able to get access to because of that, and now he's able to? Was there? I don't know if you knew the condition or condition.
Yeah, I don't know the condition, but what it means at a high level, and Kes, definitely jump in if you want to help me on this one. But at a high level, what it means is that this individual right now has complete Medicare and Medicaid. When they were partially dual, they really only had Medicare with some of their copays being picked up, which is a good thing, right? But now this individual has full access to both of these programs, right? And it is a more durable pathway to it, right? It's not going to necessarily have the renewals necessary to keep that benefit. Guess I don't know if you want to jump in on that at all.
Yeah, I was just going to say a lot of the plans that are not a DSNP, right, might have a deductible or co-insurance on hospitalization, might have higher copays in exchange for a zero premium. Still in New York, most plans are zero premium, but there's still some other costs associated with that. When you get that Medicaid wraparound and it's integrated, you don't have to pull out two separate cards. Your card identifies you as a full Medicaid. You don't have to pay those deductibles and co-insurance. You pick up some extra benefits that New York Medicaid in this example covers around transportation and dental. So you're still getting your Part B premium, the $170 put back in your Social Security check, whether you're partial or full, but your cost of care is reduced this way as well.
It's really compelling when you're on the phone with them, I bet. What about so Sean, you mentioned, and I know we're just talking with general numbers, but you said thousands and then hundreds. So to me, it's like you converted like at least 10% of the partials to full. Any sense of what that means for an uptick for revenue for the health plan in New York?
Yeah, I mean, it's going to be hundreds of dollars for every single member that gets converted, hundreds of dollars every month, right? So if you take your DSNP population, we tend to have most of our success in the QMB category, right? So these are the partial duals that have the highest level of partial dual benefits. So we tend to start and really look at QMB members and say, okay, how many QMB members do you have? And how many of those are going to qualify for full dual? And it's going to vary a lot by state. And that's because Medicaid varies so much by state. Some states, there's a lot of pathways to get them full dual benefits. Some states, it's harder to get them full dual benefits. But what you've got is, if you look at that QMB population, really every single one of those members should be evaluated to see if they could become a full dual, even if that's QMB plus full Medicaid. And that'll be hundreds of dollars PMPM for every member that gets converted.
So really conservative back of the envelope, and tell me if I'm missing something here. You know, if we're leaving, let's say you said hundreds of dollars a month, let's just say it's $100 a month, that's $1,200 a year. We're talking about, if you're able to convert 1,000 members, we're talking about we're talking $1.2 million a year right there.
Yeah, and it's definitely north of $100, at least double that, if not more, and depending on the particulars. So yeah, it's a lot of money.
Okay. What about let's do another one, Keslie. Do you have could we cover another bright spot that maybe you could share with us? Give us some more inspiration here.
Yeah, I think it's really comes down to the outreach and being able to cast a wide net. So Josh was speaking about what their goal is, right? It's really to create a better member experience and to help a wide range of people. Not everybody's going to qualify for a Medicare savings program or full dual. That's pretty low income still, $1,500 or less a month, right? So if you can cast a wider net and even go up to the low income subsidy at 150% of federal poverty level or 1,700, or start outreach with some community assistance programs. And that way you're not asking people to raise their hand at such a low level, because this is still a really proud population, right? After you develop a relationship with them, after the conversation kind of evolves, you might find out that they qualify for as a full dual as well, right? But you started the program by talking to them about what their challenges are, identifying that. Everybody talks about social determinants of health right now and how important that is. But there's not a lot of immediate ROI with helping somebody get enrolled in a utility discount, right? But it might be really important to that member that's financially insecure and not being able to turn their air conditioning on in the summer. But if you start that with something that doesn't have income and assets, you help them to get enrolled, and you find out as that conversation evolves that they also qualify for a dual savings, a Medicare savings program or full Medicaid. You're improving that member experience, you're casting a wider net, and you're funding that entire SDOH strategy with that dual eligible member that you find within that population.
Do you have a specific example of an organization that's doing exactly that?
All of our clients. Yeah. So just about all of our clients are allowing us to start with a wider net, where we reach out to people and say, hey, there's community assistance programs that you might be eligible for. They don't require income and assets. They don't require documentation. Let us talk to you about what your challenges are and help you become enrolled in these populations or in these programs and learn about them, right? And then the conversation and the eligibility screening evolves to say, hey, you're also eligible for the low income subsidy. That's going to help you lower your drug copays. That's one of the biggest complaints that a Medicare Advantage plan gets right now, is the cost of medication, right? And it's a non-documented application. It's through SSA, lowers their drug copays within, usually they get approved within 30 days, right? It's immediate gratification for that member.
Okay, let's do this, because I want to get folks to get their pen and papers out, and let's start creating a little bit of a blueprint here. And I'll start with you, Sean. What are some things that a plan needs to have in place to accomplish everything that we just spoke about? And then Josh, I'll have you come in and add your perspective on the health plan. And then Keslie, if they missed anything, we're going to have you kind of fill in. We'll do it that way. So Sean, let's start with you. Like, what are some things that need to be in place?
So it all starts with an outreach strategy, right? That you need to engage members. And there's two different populations. We're talking about two different things here. You're going to need to engage members that are not currently dual, right? But that you have some sort of indication that they might be eligible to become dual, right? And so this is a population that really need to build that human to human connection. Typically, we really recommend doing live representative calling, right? People are going to respond very poorly to recorded messages, that type of thing. You want to get a human being on the other end of the line. For the people that are not dual, you want to engage with them, build their trust, solve challenges as you're going, and then look for the opportunity to see if they can become dually enrolled. And you need at the same point in time that outreach program going to the partial duals, again, solving some of the same challenges, getting that engagement going, building the trust, and understanding how many of those folks that you can convert to full duals. And in both cases, what's really important is that whatever state you're in, you need to have every single Medicaid program accounted for. You need to understand the eligibility limits, not just for the wide big ones. We talked about ABD before, we talked about Medicare savings programs, but we also talked about working disabled, right? You need to understand all the different opportunities that are there to get somebody full Medicaid, ideally, right? And you need to understand the income requirements, the asset requirements, and the application requirements for each one of those programs. So you need to make sure that you're really getting down there into the specifics and understand each of those elements. And I would say more than anything, what you really need is a plan. You really need to say, hey, listen, we understand that there's folks that are eligible for dual benefits that are not there, not dual currently, and we understand that there are partial duals that could become full duals. So how are we going to have this outreach program? How are we going to help them through the application process? And how are we going to monitor that application, engage with the state where necessary? And that's where government relations comes in, and make sure that the person gets the highest level of benefits for which they're eligible.
All right, let me summarize what I just heard here before I bring in Josh. I heard first outreach strategy, if you're taking notes. And underneath outreach strategy, I wrote two things: those who are not currently dual but may be eligible, and those that are partial duals. And you went into details on both. The second thing I heard is know your Medicaid programs within your state, and there could be multiple, and the eligibility limitations of each program. You also, and for example, you talked about people who are working but with disabilities. So that was an understanding their application requirements. So I heard outreach strategy, know your Medicaid programs as 1 and 2. You said need a plan. I think I summarized one of the things I heard you say there, because I think this overall is sort of, we're trying to outline a plan for them, would be a process to get those applications completed. So I counted that as number 3. So I'll call it an application completion process. God, that's not a very technical or professional, but that's what I'm trying to get at. So far, I have 3 things. Keep me honest here, Sean, before we move to Josh. Outreach strategy, know the Medicaid programs in your state, and an application completion process or program.
Yeah, and just to build a little bit on the need a plan thing, one of the biggest barriers to doing this type of work is making sure that there's organizational understanding that this is a challenge, right? That there are people who are not dual who could become dual, and that there are partial duals that could become full duals. Even despite the fact that there might be an advocacy program in place, you got to make sure, is this really understood and is this really being addressed? So awareness of the opportunity is really the first thing that you need.
Okay, so I'll buy into that sort of a SWOT. So I'll say number 1, understand the opportunity and the challenges that come with it. Number 2, the outreach. Number 3, the state Medicaid programs. And number 4, an application completion process.
Absolutely.
All right, beautiful. We got something here. Josh, jump on in. What else do we want to add?
Sure. No, Sean really covered this. I mean, from a vendor perspective, all of those things that the plans typically don't have in place would all be really, really helpful in reaching out to these members and getting them enrolled. From the plan's perspective, you really do need some staff that understand the coordination between Medicare and Medicaid. You also need staff that understand how the eligibility and the payment structure works between Medicare and Medicaid, and how the benefits then go to the member, so that, as Keslie mentioned before, I don't think we can overstate the importance of these cost savings to the member. So you need staff that understand, when we do this as a philosophy, these members will be saving on their Part B premium alone, $170 to $200 a month. Plus, they will no longer have the copays, the deductibles that they currently have, even on the zero premium products, which is where most of our members are today. So they'll have no out-of-pocket costs for their healthcare, for all intents and purposes going forward. And I think as an organization, as a payer, if you have that understanding internally and that philosophy, you can find a partner that helps you with the outreach plan, with the communication with the members, and ultimately with the application process, which is very complicated and different in every state.
All right. So I added 2 from that. Josh, tell me if I captured this accurately. I heard an opposite order that you mentioned it, but in order that I would put it in the plan, a marketing / communication / script strategy. Like, we need to understand how we're marketing and positioning this to the members, exactly what we say to who we say it. That's complicated. I don't want to get into all the different idiosyncrasies there. You probably want to outsource that, but you need to have that in place. A marketing / communication strategy a marketing communication member strategy to make sure that we got the onboarding there. And the second thing that you said, I think, is super important and should not be understated, is a staffing strategy. You need to have folks who are Medicaid experts on your side of the fence, and probably working with folks outside of your organization who are Medicaid experts to really understand all of this to make it work. So I added those 2 to our blueprint: marketing communications, member marketing communication strategy, and staffing strategy.
Absolutely. Nope, that sounds great. The culture philosophy feeds into that marketing strategy. And I think, here at Network, that's something we really try to work hard at. So
That's interesting. I don't think I'm going to put that in the plan. I think that's either drives the development of the plan or results from putting together a really good plan, especially understanding those opportunities and challenges. But it certainly should be noted as really important that you have to have top down and bottom up buy-in here. Keslie, did we miss anything?
Now, I would elaborate on what Josh said about training and awareness within the plan. Like anybody that can speak to that member or that does speak to it, to be aware of what the outreach and what the goal is to help people get enrolled in these programs is really crucial. One, you want them to validate that the outreach is taking place, right? Internally or with a vendor, but you also want them to be able to refer, because you're going to find membership that doesn't respond to mailings, that doesn't pick up the phone, but that talks to their care manager every month, right? Or maybe they only come to community offices. And if you have a flexible vendor that can staff that community office with an advocate or show up at member events, you're going to find members that respond to outreach in different ways. And you want to be able to cover all of them and have all your staff that might be interacting with that member be aware of these programs.
Okay, so I'm going to add, I'm not going to add I'm going to add 2 sub-bullets to our plan under marketing and communications, member strategy, who delivers the message and where's that message delivered. I think that is important. I'm typing as I talk. And then under the staffing strategy, making sure that you have a training and awareness program as part of that staffing strategy. Love it. That was great. That was great. All right. So I think we have it all down here, folks. Understand your opportunities and challenges, have an outreach strategy, the Medicaid programs in the state, know them. Number 4, a marketing and communications member level strategy. Number 5, an application completion process. And number 6, a staffing strategy. And obviously points below each one of those 6 things. That's your blueprint for making sure you can convert as many currently non-eligible and partially eligible to fully eligible DSNP members. Great stuff. Any last thoughts before we close up here? I know we're getting tight on time.
Just add one thing, right, which Eric, I think that summary was awesome, is that also it's not a one-time thing, right? This is an ongoing challenge, right? So somebody might not qualify today, but then they develop another condition, they're incurring more medical expenses. So you need a method to keep engaging, keep checking so that it's an ongoing process and not a we did it once and now we're done with it.
Great. Where can people find you to pick your brain, ask you any follow-up questions? Josh, where can people find you?
Sure. Networkhealth.com. You can go on our website and kind of look it up. And, we are a regional health plan in Wisconsin, generally from Green Bay down to the Illinois border. So, about 130,000 lives, regional plan. So if they want to find me and find Network Health, they can go to networkhealth.com.
Go Packers.
Right.
What about Sean and Keslie? What about you guys?
The best place to reach us is probably the website as well. Easiest to find us at BeneLynk.com. Our contact information's on there, as well as a button where you can just send us an email.
Great. I'm going to spell that for everyone just in case. It's BeneLynk.com. Excellent job, everyone. Really, really appreciate it. Appreciate all of you who took the time to listen. I hope you got some value out of this. I think you should have. Feedback always welcome. eGlazer at sharedpurposeconnect.com. Look me up at Twitter, Eric Glazer, or on LinkedIn. Always want suggestions on how we could be better. I always like saying we do not take for granted the hour or 45 minutes that you spend with us each and every episode. And I like to think that Bright Spots in Healthcare is your podcast. So want to make sure that we're delivering for you each and every time. This will mark the end of the show. Thank you again to Josh, Sean, and Keslie, and have a good rest of your day, everyone. Thank you.